We're going to do bronchiolitis. We are in prime bronchiolitis season. However, we are not seeing much of it. And it's kind of interesting. The reason we're not is this is 2022. Kids have been wearing masks for an extended period of time. All the little viruses that used to, bring kids into the emergency department have been limited because of all the social distancing and the kids washing their hands and much more attention to respiratory problems. So we're not seeing a lot of bronchiolitis. We actually saw, it was very interesting, in our shop, the second kind of drop after Delta, all the kids went nuts and we saw a ton of bronchiolitis. And then as soon as Omicron came and everybody started to hunker down again and got back to masking and social distancing, all the bronchiolitis went away again. So, but it is not going away permanently. It's going to be like COVID eventually. It's going to be, and it is endemic. So you're going to see them again. And the question is, what do you do with a kid with bronchiolitis? And the answer is, well, we'll wait till the end of the lecture and I'll give you the answer. All right. This is a series of articles, and all of you who have taken care of kids with bronchiolitis know how just how frustrating it is. The kid comes in and they look exactly like an asthmatic. They're wheezing, they're coughing, except that most asthmatics don't have enough of a runny nose that they've smeared it all over their face. But the kids look exactly like an asthmatic in the way they present. So the question is, treat them like an asthmatic. And the first article says, what happens if you give them steroids? Should you be giving steroids to kids with bronchiolitis? And this is a literature review, and it looks at oral corticosteroids in kids with wheezing without a diagnosis of asthma. So you got, Twinkie comes in, 10 months old, wheezing like crazy, and you look at them and their pulse ox is a little shaky, they got some retractions and whatnot. Should you give them some steroids? And the authors identified 4 randomized controlled trials, and what they found was that they showed no benefit. 3 of them showed no definite benefit, and one was one of those, well, maybe in some subset it might be of some value, but overwhelmingly there's no good evidence that steroids work in kids with bronchiolitis. Here's the kicker though, and all of you have seen it. There's a kid that comes in that looks just like bronchiolitis, only they turned out to be their first asthma episode. And we've all seen that. So the question becomes, well, the steroids would certainly help a kid with asthma. Should I be giving steroids to all these kids that present this way? And the answer is no. And the problem is the following, that they really can't predict, looking at that child, whether they're an asthmatic who's got their first episode or whether it's just a garden variety bronchiolitis. So what they say is, you really shouldn't be doing it. Now, these authors also said, well, if you carefully get the history, if the kid's got some eczema and there's a family history of asthma and there's a higher chance that this kid might have asthma and not bronchiolitis, you can go ahead and give them steroids. I'm not buying it. These kids don't need steroids. They have bronchiolitis. The last 4 kids you saw have bronchiolitis. This kid's got bronchiolitis. Number 2 looks at albuterol. Okay, we're not going to give them steroids. Got to give them albuterol. The kids are wheezing, right? And again, they try to find a subset that works. This is from the group at Connecticut Children's Hospital. They had 25 kids who were mechanically ventilated for bronchiolitis. So these are sick kids. This isn't the kid that's rattling around the cage in your department, shaking the bars on the crib there. These are kids that are in the ICU. And what they looked at was, could they predict which of these kids would get better with albuterol? And they were looking for a 20% improvement in the physiologic parameters considered as an albuterol response. Did their peak pressures go down? Did their respiratory rates go down? Those kind of things. And what they found was that actually in 36% of the kids, about a third of the kids got better with the albuterol. So these are intubated kids. They're just sticking it in the ventilator there. And so they said to the respiratory therapists, the nurses, and the docs, we want you to predict which kids are going to get better. So that, before we give them the albuterol, is Irving over here going to get better than Tiffany over here and whatnot? And the docs were about 48%. So they're about a 50-50 split. The docs and nurses and everybody else just had 0 predictive value. So they're better off just flipping a coin. So the authors conclude that clinicians can't make a prediction as to who's going to get better. Here's my thought on this. It's not like it's a CAT scan, or you guys are talking about MRIs for the subarachnoids and stuff. It's a nebulized albuterol. Just give the kid a dose. Give it a try. And we do it all the time. Kid comes in, they look like they're bronchiolitis, but you know what? Maybe they're asthma, maybe they're going to respond to it. You give them a nebulized albuterol. It's, a couple cc's, mom sits around for an hour. It's incredibly entertaining you see all this steam coming out around the kid's head. The family thinks you're doing something for them. Sometimes it works. I mean, I would say that, periodically you see that kid that just gets dramatically better. And it's like, I didn't think you had asthma, or I didn't think you had a entity that was going to respond to a bronchodilator, but son of a gun, you did. And the bottom line is, if you look at this paper, it works in 1 out of 3 kids. About 30% of the kids are going to get some type of a positive response. So I don't see any downside to giving albuterol. Now, there's a lot of people who are emphatic about, my God, you got to be a blithering idiot if you give a bronchiolytic albuterol. It's in that case, you tell them it wasn't a bronchiolitis. It was an asthmatic with a viral infection. Just leave it at that. So if they say albuterol doesn't work, great, and it doesn't, but it still works. I think a lot of times it may be just the humidity from it. We begin the search for something else. Abstract number 3 says hypertonic saline. Let's go ahead and nebulize hypertonic saline. This ought to work. I have no idea what the thought process was. That must have been like a bunch of people at the bar, and they said, hey, you know what? I wonder if hypertonic saline would work. 776 kids, at first episode of bronchiolitis. They were randomized to hypertonic saline or just nebulized saline, normal saline. And mean age was 3 months of age, so these little kids. And what they found was hospitalization occurred in 48% of the kids with hypertonic saline and 52% with normal saline. So it didn't work. It flat out didn't work. However, the respiratory distress scale did improve in the hypertonic group. I have no idea. If the respiratory distress scale improved, you would think that they didn't have to be hospitalized, but I guess it didn't make any difference. The authors conclude that hypertonic saline is probably not useful. To be perfectly honest with you, by the time we found hypertonic saline in our department, the kid would already be better. So it's not worth doing in our shop. Magnesium. I think it was at the same bar they came up with nebulizing magnesium on these kids. Actually, this wasn't. This was IV magnesium. Okay, I did not want to be part of this study. You got this pudgy little 6-month-old who's got bronchiolitis, and they tell you have to put the IV in them to go give them magnesium. The kid didn't qualify. They had some reason they had to be out of the study. At any rate, 86% had positive nasal swabs for a virus, probably RSV, and the mean age was 3.7 months. All right, there was no statistical difference was seen time to discharge severity scores or later clinic visits. So again, magnesium did not work. Moving on, nitric oxide. Not nitrous oxide, nitric oxide. This is a pulmonary bronchodilator or a pulmonary vascular dilator, and it's also supposed to have some pulmonary dilation effects as well. This is an Israeli research group, and what they did was double-blind trials randomizing 43, and then they did it again with 69 hospitalized patients. So these kids are sick. They're in the hospital. Now the key is let's see if we can get them out of the hospital. So what did they find? They looked at the safety and the efficacy, and pretty much it didn't work. The efficacy outcomes were a little bit shorter length of stay, but otherwise their SiO2s didn't improve any. Methemoglobinemia is a problem with nitric oxide, but they didn't have any problems with that. So the bottom line is they were unable to show any real benefit of it, and this would be something that most of us don't have ready access to. So nitric oxide is off the table. Number 7 is a network analysis, and what they looked at was all the possible sources, and they compared them. Steroids plus albuterol, albuterol alone, albuterol plus magnesium, magnesium plus shots of bourbon, all that kind of stuff. And no, it works well. You just have to have the parents take it. No intervention demonstrated reliable or credible clinical important benefits. This included nebulized hypertonic saline, salbuterol, epinephrine. There were articles that used to show nebulized epinephrine had some value. And I will tell you, if I have a really sick kid and getting ready to intubate him, certainly that's in my toolbox before I put the tube in them. They showed hints of potential benefit, but the authors report overall confidence intervals were low to very low for these things. And the other thing they point out, and this is up Ken's wheelhouse, is that the strength of evidence in most of the studies that show any kind of benefit is either poor or very poor. So not much there. Next article looks at the one thing that absolutely works and works incredibly well is high-flow nasal cannula. Now, it's interesting when you look at the studies. There's some studies that say it worked. There's people who are detractors of it. Part of it is you have to recognize how high-flow nasal cannula works, and it's not BiPAP light. And the way it works is the following. If you look at a neonate, a newborn, and this is how they figured it out, because it was the neonatal physiologist figured this out. When you look at them, if you look at their tidal volume and their dead space, so the dead space is from the tip of their nose down to their bronchi, all the way down to their alveoli. And then the only area that's exchanging any gas is their alveoli itself. If you actually do the calculation, you look at the amount of dead space and their tidal volume, they don't move enough air to survive. They don't move enough air in and out. They're basically exhaling and rebreathing the same air they exhaled. So they're rebreathing air that's got a PO2 of like, or an FiO2 of 13% at best, and a PCO2 of like 40. So what they do is they breathe very fast and they breathe through their nose. That's what you've always heard, neonates are obligate nasal breathers. And the reason they do that is for us, from the nose all the way down, that's dead space. For them, it's not. They create these vortices in their nasal pharynx where they wash out their exhale gas and wash in the new inhale gas. So they're actually using what we would call dead space as an exchange area where they're exactly exchanging gases. What the high-flow nasal cannula does is it duplicates that. That's why it works the same way in adults and works in children. So what it's doing is it's washing out their exhaled gas, all the exhaled gas with the low O2 and whatnot, and it's replacing it with whatever you want to give them. It's got a 0 CO2 and whatever FiO2 you set on them. So you can actually set these things at 100%, and the kid will get 100%, even if their mouth is open. So when you put it on somebody with bronchiolitis, it makes it easier for the child to breathe. They don't have to move as much air in and out to lower their CO2 and to raise their oxygen saturations. And if you're a fan of it and you use it, you watch these kids, they're working really hard. They got these retractions, their respiratory rates are 70, 80, and you put them on this, and within 5 minutes, respiratory rate comes down, retractions go away, sats go up. And the other thing it does is it's highly humidified. You have to humidify it, because if you're going to blow 30 liters up somebody's nose, well, kids aren't that high, you're going to dry them out. So it's very, very humidified. And what it does is it kind of moisturizes all the gunk they have in there, and they cough like crazy. When they first started bringing this to market, all the pediatricians were saying, you put that on there, and my kid's coughing their brains out. And they said, just give it 10 minutes. Kids cough like crazy. 10 minutes later, they've moisturized, moved everything up, and they do a whole lot better. This is a randomized controlled trial. It looked at need for mechanical ventilation, and what they found was escalation to care from normal care, or if you took a kid with bad bronchiolitis and put them on high-flow nasal cannula, the difference was 12% on the high-flow group versus 23% on the usual group. And this is just one of a whole lot of studies that have found that it works really well. Now, if you're so inclined, it works really well in adults. For asthma, it works well for COPD because it'll blow off their CO2. Their CO2s just drop. Works well for DKA because they're with the Kussmaul breathing. They don't have to breathe as fast to lower their CO2. They can breathe easier with this on it. It does not work as well for CHF. BiPAP is clearly better for CHF. Now, there is an opposing point of view, as there always are, and seemingly, I'm not sure why, the opposing points of view always come from somebody at a very prestigious institution who has not been to the bedside. And this is one of the things where if you use, how many people have used the high-flow nasal cannulas? Yeah. If you're at the bedside, you look at it and you go, oh, I've seen how these kids react to other things, and they react very well to this. If you're in your office and you don't see kids, you get to write an article. So this guy wrote a dissenting opinion, and he said, well, look, it didn't really work. It didn't change the length of stay. There are lots of adverse events. I'm like, what adverse events? He said, well, there's gastric distension. There's poor feeding. It's like, no, actually, I see that it's nasal cannula. They can feed with it. And he said, based on these data, 30% of early applications of high-flow nasal cannula in trials were unnecessary. I'm not sure you could say that. And his ultimate thing is the following. The use of high-flow nasal cannula seems to be useful only for preventing the later use of high-flow nasal cannula. Okay, if you used it and you prevented it from being used like 6 hours later when the kid was sicker, didn't it make sense to kind of use it earlier? But at any rate, there's always a curmudgeon somewhere. Here, and he said it's very expensive. It's not very expensive. The cost of one of those units is about $2,000. You can have a bake sale and get one for your department. They're easy to set up. You don't need to be in the ICU for it. That's the nice thing about it. You can put them on the floor and they can use it. There's a decrease in respiratory effort. And even if it doesn't absolutely decrease length of stay, you look at the kids are much more comfortable. And it's very entertaining for the parents because it makes a lot of noise. So it looks like you're doing something. How many people during the COVID pandemic proned patients? How many of you guys have proned patients? Yeah, everybody did, right? And so what this next article says is, what happens if you prone kids with bronchiolitis? So you've got that kid that's really working, and you've got them either on high-flow nasal cannula or whatever it is that you used for them, and you're going like, this kid's heading towards an intubation. What happens if you prone them? Well, these guys looked at something. This is a French study. They were looking at kids that were already on CPAP, so on 7 centimeters of CPAP. And then they put these esophageal probes down them so they can measure respiratory effort and everything else. And what they did is they looked at kids in a supine position and then they proned them to see what would happen. And there's a fancy pressure time product per minute number that you can look at when you do these things. And what they found was when they proned the kids, this number improved dramatically. The kids' SATs went up, the kids' respiratory efforts went down. So what it says is, gee, if we were using this for another viral infection, why don't we try it on the kids? So what they found was if you have a kid with bad bronchiolitis and they're not turning the corner on you and you're a little bit worried you have to intubate them, go ahead and prone the kid. And because we're so used to managing sick people in the spine position, prone them, put them on nasal cannula, CPAP, whatever it is you need to put them on, and see if their SATs improve with that. Number 11, abstract 11 is a great study. It just goes to show that those of us who practiced before the era of pulse oxes, I remember when pulse oxes first became available, that it was actually, we were better off not knowing what a pulse ox was when we managed sick kids. What they did was the following. It's a group of Toronto pediatricians, and what they did was they took the pulse ox value on some of the kids, they put the pulse ox on them and got the value, and then another group of kids, they took the value, but then they increased it by 3%. So if you had, one group of kids here and their real pulse ox was like 90, and you're like, that's a little bit low, maybe I need to admit the kid. The other group increased it, so it looked like 95%. Or 94%. You're going, 94% is pretty good. I can send this kid home. And then they looked at what happened to them, which is kind of dicey. You're telling people that their pulse ox is better than it actually is, and then you're getting the docs to send them home. And indeed, that's what happened. The docs, if they knew the true value, they admitted the kids. But when they got the fake value, they discharged the kids. So 41% of the time they admitted to kids who had the real value, and then 25% of the time they admitted them. So 75% of the time they sent them home. Even though the values were the same, they didn't know it because they had the fake value. And it turns out it made no difference at all. Kids did absolutely fine. There was no difference. And their argument is, you know what? Take care, manage the child, not the machine. So, it's nice to get the pulse ox if it's in the 80s. Yeah, you're going to worry about it a little bit. But if the kid looks really good, and the pulse ox is still like around 90, don't manage the pulse ox, just manage the kid. The next one is kind of a strange study. The use of intermittent versus continuous pulse oximetry for non-hypoxemic infants and young children hospitalized for bronchiolitis, a randomized clinical trial. This thing makes not a lot of sense to me, but the primary outcome they were looking at was length of stay. And what they did was they took half the kids, got a pulse ox put on them, and they left it on them. The other half of the kids, every couple hours somebody would come in and put the pulse ox on them. And what they found was they were looking at the length of stay, and the length of stay was 49 hours for the people who had the continuous pulse ox and 46 hours for the intermittent pulse ox. And their conclusion was, you don't have to have a pulse ox all the time. You can just, take it periodically, like when you go in and take their temperature or something like that. Number 15 is an identical study. They looked at intermittent versus continuous pulse oximetry, SaO2 monitoring, and they said no difference. From an emergency medicine perspective, it doesn't make any difference to us. You got the machine there, you got the kid there, you got a finger there, just put the thing on and leave it on them. But when you look at it from the hospital's perspective, they've got this pediatric ward with 36 patients on it, 30 of which have bronchiolitis that October. They don't have that many machines. Their argument is you can get by just periodically measuring the SaO2s, and it kind of makes sense. You don't measure the temperature continuously. You can do the same thing with them. Number 14 is a little bit of a funny study. It's a article that's saying that treatment for bronchiolitis should be restraint on the part of the physicians, i.e. don't do anything, which is true. We shouldn't be doing a lot for them, but I think it's still worthwhile to make an attempt, see if they respond to the albuterol, maybe try a little bit of change of position, see if that helps any. You have to do something. I mean, these parents who bring these kids in are scared, and for you to just blow them off as, look, they have a viral infection, kids have survived it for decades, just go home, mom, is not fair to them. You have to do something to reassure them that the child's going to do better, and as Rick always taught me, it's part of the show. You have to show that you care about that child. So they're telling you the mantra for most children with bronchiolitis is don't just do something, stand there. You have to do something. Even if you nebulize saline to loosen up things, you have to do something for them. Number 15 is an article that said, okay, we put together this program to stop doctors from treating bronchiolitis, and they looked at, we did education, and we hid the albuterol, and we took away their steroids, and what we found is in the hospitals where we did that, 85% of the interventions in the hospital were decreased, versus in the control hospital where we just told the docs about it, only 73% of the time did the docs follow the instructions. So it really basically said what we all know. You can't tell docs, nurses, PAs, advanced practice nurses, nurse practitioners what to do. You have to kind of make it so that they can't do the wrong thing. There's a question about testing for RSV. Should you test kids with bronchiolitis for RSV? I am a big fan of the first couple you see wander into your department that season. It's worth testing them, because then you can say, okay, RSV has hit the town, and then after that you don't. The only time you have to test them is if you're going to admit them to the hospital. It makes it easier for the hospital to cohort them, but other than that, there's really no need to test it, except for the really little ones. If they're under 4 weeks, some people say under 6 weeks, they have a higher risk of apnea, you need to test those kids, because if they have RSV, there's a risk for apnea there. Number 16 looks at the risk for apnea, and they found that the following criteria. And we've all had that kid that, is like, oh yeah, the mom, they don't look too bad. We're going to watch them for a little bit in the department, and then the pulse ox goes down, and the nurse looks in, and the kid's just not breathing. It's like, yeah, that's called apnea. We're going to keep this kid in the hospital. These are the criteria: full-born infant less than 1 month of age, 4 weeks. They're less than 4 weeks. They have a higher risk of apnea. You got to put them in the hospital. They were born preterm, i.e. less than 37 weeks estimated gestational age, and they're now less than 48 weeks from estimated point of conception until now. So it's basically a more liberal cutoff for kids who are premature. And the parent or a clinician has already witnessed an apnea episode. Okay. That's I know you watched him stop breathing, but I don't really believe you. I'm going to send him home. No. Mom says, Twinkie stopped breathing, Twinkie stopped breathing. So you got to take it at face value there. 17 looks at major medical interventions in kids, and it's pretty much the same criteria. The major medical interventions will be administering oxygen, intravenous fluids, apnea management, or admission to a critical care unit. That's pretty major. And we didn't talk about that. These kids get dehydrated. They can't feed. So a lot of them do require an IV to get them hydrated up. And you put the IV in them, you give them 15 cc's per kilogram, and you come back 45 minutes later, and the kid looks great. So that's something to consider on them. What are the risk factors for a major medical intervention? If their O2 sats were less than 92, I'm surprised at that. Usually you take 90 as a cutoff. Respiratory rate greater than 60. That seems to be a magic number for all of us. You need a respiratory rate of 60 in an infant. You kind of raises your hackles on the back of your neck. You're going to take a really closer look at them. And then poor fluid intake if the kid's dehydrated. All right, we have a couple minutes left. What are the AAP's recommendations, the American Academy of Pediatrics recommendations? And they're basically exactly what Rick summed up in this article, with the articles he picked here. The following are, bronchiolitis is a clinical disease, and severity is based on your history and physical examination. Clinicians should assess risk factors for severe disease, such as age less than 10 weeks, a history of prematurity, underlying cardiopulmonary problems. Obviously, if you've got a kid with a cardiac issue, you're going to be a little bit more conservative with them. Radiographic or laboratory studies should not be obtained routinely, and that's true. There's no reason to get a chest x-ray. You know, if you get the chest x-ray, you're going to see that little ditzel of an infiltrate. Somebody's going to, and the radiologist will read it as pneumonia, and now it's like, am I going to give this kid amoxicillin? Clinicians should not administer albuterol. And they give that a strong recommendation. That's absolutely true if you're absolutely positive it's bronchiolitis. If it's the kid's first event wheezing and you're not really sure, I don't see any downside to giving the kid a nebulized albuterol. And again, it's very, very entertaining. They should not administer epinephrine. Okay, that makes sense. Unless you're just about ready to intubate the kid and you want to give it one more shot with nebulized epinephrine, there's not a bad thing about that. Nebulized hypertonic saline should not be administered. Okay. Clinicians may administer nebulized hypertonic saline if they're admitted to the hospital. And there were some studies that we didn't cover here that showed that hypertonic saline in the really sick ones might shorten the length of stay. Should not administer systemic steroids. We already talked about that. You may choose to administer supplemental oxygen if the oxyhemoglobin saturation is less than 90%. Anybody here from Utah or that Colorado? You guys send them home on oxygen, right? Yeah. That's the first time I heard about that. I'm like, what the hell is this, like a high altitude thing or something? What is it? Like, Mom, here's this big green tank. You just yeah. But your respiratory therapist set it up for you, and they set it up for, what is your, there's a young lady, for those watching on camera, can't see, there's a young lady over here from Colorado who said, yeah, we do it all the time. What SaO2 do you guys send them home? What pulse ox? Okay, so if you put them on, for those, you can't hear it on here, she said if their O2 sat's 90 and they're only on 1 liter of supplemental oxygen, you'll send them home on it. Brave person. No, it's funny. I'm from New Jersey. We're at sea level, so we're afraid to do that. Clinicians may choose to use continuous or intermittent pulse oximetry if you're admitting the kids. Do not use chest physiotherapy. We didn't talk about that, but pounding a kid in the lungs doesn't help. And don't give them antibacterial medications. Antibiotics aren't going to work for it. You should administer nasogastric or intravenous fluids if they're dehydrated. If this poor kid's got this stuffy nose, there's mucus running out of it, you're going to stuff an NG tube up there as well? It's like, no, we'll put the IV in the little guy there. All right, so now you are completely up to speed on bronchiolitis, except if you're from Colorado, in which case you got to figure out how Mom's going to carry that big oxygen tank home with her. So.